Okay, we are going to continue from looking at this slide. So I mentioned that we're looking at fat cell differentiation. This AP2 gene became a very good indicator for kind of to let us study the differentiation between the fats, between brown fat cells versus white fat cells. And again, it began back in the 1990s. This so-called what we call master gene of white fat cell development. And so it's looking at the metabolic differences of how brown fat converts food into heat, right, wasted energy, rather than what occurs in white fat to produce ATP that we use for cellular activity. So as the body increases, fat increases, right, adipocytes eventually reach a biological upper size limit. Once this occurs, the cell number becomes the key factor that determines any other further fat accumulation. Even doubling adipocyte cells does not explain the large difference in total fat mass between an obese or an average sized person. So for comparison, an average sized person has between 25 and 30 billion adipocytes, whereas clinically severe obese have more than 3 to 5 times this number, particularly when excessive fatness occurs in childhood or adolescence, right? It's been there for a long time. Differences also exist in the composition of the fatty acid structures in the perivisceral, subcutaneous adipose tissue regions among overweight both males and females. Here's a figure, just a comparison of body mass, total fat, and adipose tissue at the cellular level. So these are 25 subjects, 20 are whom would be classified as clinically obese. So kind of looking at the differences in the size, right? So you've got muscle, you've got fat per cell, and you got numbers per billions, kind of that comparison breakdown. So when subjects attained a normal body mass of, let's say, 75 kilograms, right? So they got to 75 kilograms by losing an additional 28 kilograms. The cell number remains unchanged, right? There's really no change. However, the size continued to shrink to about 1/3 in that of a non-obese comparison group, right? So when patients achieve what we call normal body mass and body fat level, adipocytes had become considerably smaller in size than the non-obese. In adults, the major change in adipose cellularity and weight loss is the shrinkage of the adipocytes, with really no change in cell number. So these findings suggest that weight loss in obese persons does not really so-called cure obesity, at least for a total adipocyte number. So when caloric intake decreases and the subjects again are able to attain normal body fat, body fat is declined, then the adipocytes revert to their original size. So in general, moderate weight gain from overeating in adults, right, enlarges the size, enlarges the existing adipocytes rather than stimulating new cell development. So this figure is showing you a classic study of weight loss effect on adipose tissue characteristics. So this study looked at 19 obese adults during 2 stages of weight loss. During the first stage, the subjects reduced body mass by 46 kilograms. So they went from 149 down to 103 kilograms. So they had a 46 kilogram weight loss. Adipocyte number before weight reduction averaged 75 billion cells. This remained unchanged even after the 46 kilogram weight reduction. In contrast to this, adipocyte cell decreased by 33% from 0.9 to 0.6 of per cell, the lipid per cell number. So just looking when you talk about hyperplasia, right, or hypertrophy, so the size versus how many fat cells there are. So for many adults, body weight fluctuates only slightly during the year, even though annual food intake averages more than 830 kilograms. This represents a pretty impressive consistency considering the slight increases in daily food intake translate to really substantial weight gain over time, if it's accompanied by compensatory increases in energy expenditure. So we know the human body functions in according with the laws of what you know as thermodynamics. So if total food calories exceed daily energy expenditure, excess calories begins to accumulate and store as fat in the adipose cells, right? The basic laws of hemodynamics. So the first law of hemodynamics, often called the law of conservation of energy, posits that energy can be transferred from one system to another in many forms, but cannot be created or destroyed. So when we relate this into human terms, it means that energy balance equation dictates that body mass remains constant when total caloric intake from food equals caloric expenditure, right? The latter includes what we know as the thermic effect of food, the TEF, physical activity, and along with resting metabolism. This figure is showing you what you've seen. We've seen this photo probably multiple times before, right? It shows that any chronic imbalance on the energy output or input side of the equation changes body weight. So there are three ways really to unbalance the energy balance equation to produce weight loss, right? Number one is reduce caloric intake below daily energy requirements. Number two is to maintain caloric intake and increase energy expenditure through physical activity that's done above daily energy requirements. Or three, decreasing daily caloric intake and increasing daily energy expenditure. So the intervention strategies and targets that many people would try could be chemicals, so drugs, thermogenesis, right, resting metabolism changes, surgery with absorbing less food, behavioral therapy, food, how much food are you taking in, changing your meal plans, increasing activity. The objective of weight loss programs has really changed dramatically over the past decades. The previous approach assigned a goal body weight that coincided with a, quote, ideal weight based on body mass stature. That was old school, right? This achievement of goal body weight kind of herald the weight loss program's success. Currently, the World Health Organization and the Institute of Medicine, National Academy of Sciences, the National Heart Lung, all of these great organizations recommend that overweight obese people reduce initial body weight first by 5 to 15%. We need to set that initial weight loss goal beyond 5 to 15% recommendation, gives patient really an unrealistic and potentially unattainable target in light of the current treatment methods. The first, So we talked about the weight loss being 5 to 15%, right? We did that. So when we look back to the laws of thermogenics, affirms that weight loss occurs whenever energy output exceeds intake, right? That balance, regardless of the diet's macronutrient mixture. Advantages of relatively high percentage of unrefined complex carbs in a reduced calorie diet include moderate to low glycemic index. It could be high vitamin, mineral, photochemical content. It could be low energy density, low saturated fatty acid levels. Really a prudent dietary approach to weight loss unbalances, right? The good way is going to unbalance the energy balance equation by reducing energy intake by 300 to 100 calories below daily energy expenditure. So moderately reduced energy intake by 300 to 500 produces greater fat loss relative to an energy deficit that's more severe energy restriction. So individuals who create larger daily deficits to lose weight rapidly tend to regain the weight compared to those who lose weight at a slower rate. So really being cognizant of what we know from evidence-based research. So the potential for successful long-term weight loss maintenance generally varies inversely with the initial degree of fatness. Right, so note that that degree of obesity increases from overweight to obese to severe to morbid obese. The chance of success markedly begins to get diminished. So for most individuals, unfortunately, initial success in weight loss relates poorly to long-term success. Participants in supervised weight loss programs that include pharmacological, behavioral interventions generally lose 8 to 12% of their original body mass. Unfortunately, typically 1 to 2/3 of that weight loss returns within a year, and really almost all of it within 5 years. So that's what we know. The studies have shown this. So patterns within a year, looking back, almost all of that weight within 5 years is regained. So this figure is illustrating that over a 7.3-year follow-up of 121 patients returned to their original weight occurred in 50% of the individuals within 2 to 3 years, and only 7 people out of those 121 remained at their reduced body weights. These are very discouraging, but typical statistics highlight the extreme difficulty of long-term maintenance of low-calorie diets. It's important, particularly difficult, that in this very relaxed atmosphere of one's home with readily accessible food and very often not enough emotional support for this weight gain to bounce back again. So we know a lot about behavior modification. Right? So the use of behavioral modification, psychologists, behavioral health, a common intervention in weight loss programs provides a set of principles and techniques to alter physical activity and eating habits. So therapy increases skills for replacing existing habits with new, more healthy habits. Behavioral therapy characteristics include eating well-balanced meals with reduced portion sizes, restricting daily caloric intake by 500 to 700 calories daily, keeping meticulous records and journaling of food intake, engaging in physical activity, and increasing daily physical activity by at least 200 to 300 calories daily. So weight loss in obese individuals often exerts a really profound effect on biological factors related with disease risk. This figure shows that percent change from initial body weight and change in the actual biomarkers of risk in obese patients over a 27-month period using 2 different energy restricting meal plans. So in phase 1, during the first 3 months, group A attempted to consume an energy restricted diet of 1,200 to 1,500 calories daily compared to the conventional self-selected meals prepared by the subjects. In group B, they were assigned to the same caloric intake, substituted 2 meals and 2 snack replacement shakes, soups, hot chocolate, and snack bars. What is kind of, they used a slim fast kind of type of stuff for selected food groups. In phase 2, between months 4 and 27 months, all subjects consumed self-selected diets of equal caloric value with 1 meal and 1 shake replacement. And what they found was unequivocal results emerged from both studies. Group B, greater weight loss during the first 3-month phase of phase 1 period was attributed to a larger caloric diet created by the eating plan. And then thereafter, both groups reduced on average an addition of just 0.1% of initial body weight each month. So that would be about 4.2 kilograms for A and about 3 kilograms for point B, very similar. Really showing you the absolute changes in these biomarkers during these phases. So these are all those different biomarkers. So what we're showing you is that great things happen, really profound change in disease risk during concentrations of this 27-month weight loss program. Another thing you might be familiar of is one can lose large amounts of weight relatively short-term period by simply not eating, right? The problem, unfortunately, success is short-lived, and eventually the urge to eat outwins, and what happens is lost weight returns. Some argue that this failure to maintain weight loss represents a genetically determined, quote, set point for body weight or body fat that differs from what the person would like. So proponents of a set point theory maintain that all persons, fat or thin, have a well-regulated internal control mechanism located deep within the lateral hypothalamus that maintains with relative ease a preset level of body weight and or body fat within a limited range. So in practical sense, the set point ensures that a person's body weight remains relatively constant with not counting intake calories. Physical activity may lower a person's set point, whereas dieting exerts no effect. Each time body weight decreases below one's pre-established set point, internal adjustments that affect food intake and regulatory thermogenesis resist the change and conserve and or replenish the body fat. So an example would be resting metabolism slows, thus conserving total energy output, and the individual becomes obsessed with food, unable to control the urge to eat. In contrast, on the opposite end of the spectrum, when someone overeats and gains body fat above the normal level, their set point resists the change by kind of increasing. So this set point is really very controversial. Another one is resting metabolism often decreases when dieting progressively produces weight loss. So what we know is hypometabolism with caloric deficit often exceeds the decrease attributable to the loss of body mass or fat-free mass, independent of the person's weight status or prior eating history. So depressed metabolism conserves energy, causing the diet to become progressively less effective despite the restricted caloric intake. And this produces what we know as a weight loss plateau. Further weight loss occurs at a slower pace. So really being aware of how the metabolism is beginning to change. This figure is showing further evidence of the body's, quote, defense against even moderate fluctuations in body weight. This is very classic research that carefully monitored body mass, resting oxygen consumption, or minimal energy requirement, and caloric intake of 6 obese men over 31 days. During the pre-diet period, that's the pre-diet red, body weight and resting energy consumption stabilized with daily food intake of 3,500 calories. Thereafter, daily caloric intake decreased to 450 calories, shown in the yellow. When the subjects switched the low-calorie diet, body weight and resting metabolism decreased, but the percent decline in metabolism exceeded the body weight decrease. The dashed lines in the upper figure represents the expected weight loss with the 450 calorie diet. The decline in resting metabolism in the middle figure conserved energy to make the diet progressively less effective. More than half of total weight loss occurred over the first 8 days of dieting. The remaining weight loss occurred during the final 16 days, therefore giving us that theoretical weight loss curve that often frustrates and discourages many patients that are on following a restricted diet. Further disconcerting news awaits those who anticipate permanent fat loss. When overfat people lose weight, the adipocytes increase their level of fat-storing enzymes called the lipoprotein lipase. So that's the LPL, right? So this adaptation facilitates body fat synthesis, and the fatter the person before the weight loss, the greater the LPL production with weight loss. So in essence, the fatter one is at the start, the more vigorously the body attempts to regain the weight loss. This observation supports the existence of really dedicated biological feedback mechanism between the brain and the body fat levels, and helps to explain the difficulty overfat individuals have at maintaining weight loss. Thinking back at that set point theory delivers unwelcome news, right? Because at set point, so-called tune, that might be set at too high, encouragingly, regular moderate level intensity exercise may lower the set point level, and that's important to note. And concurrently, adaptations, arguments, the weight loss effort. So we're going to talk about some misconceptions, right? Increased physical activity increases food intake. No, right? Discuss how food intake tends to decline initially, despite increasing energy output for overly fat men and women to begin exercising regularly. So what I mean is by physically active lifestyle continues, body fat decreases, caloric intake balances daily energy requirement to stabilize the body mass at this new lower level. Right? So some research challenges the argument that individuals who lose weight necessarily maintain the initial depressed metabolism that predisposes them to weight gain. Undoubtedly, energy restriction produces a transient state of what we call hypometabolism. So if the dieter maintains the state of negative energy intake, this adaptive downregulation in resting metabolism does not persist when individuals lose weight, but then reestablish balance where energy intake equals energy expenditure at their lower body weight. Consequently, research that fails to establish energy balance following weight loss gives a very inaccurate impression that individuals who lose weight necessarily battle a prolonged kind of overcompensating reduction in resting energy expenditure until they return for their original body weight, right? That's what that kind of down regulation. Professional organizations have voiced very strong opposition to some diet practices, particularly some of the extremes of fasting, low carbohydrate, high fat, high protein diets. Extreme diets raise concern about athletes and other adolescents and young adults who routinely engage in bizarre and often really pathogenic weight control behaviors. So researchers currently are studying a subgroup of bulimia that occurs without binging, right? These individuals do not binge eat and generally maintain a normal body weight, yet feel compelled to purge, usually by vomiting, even after eating only small or normal food. So a lot of dangers of the subset of eating disorders are similar to bulimia, dehydration, or electrolyte imbalance, potential dental problems from self-induced vomiting, emotional and psychological problems, including body image problems, anxiety, and depression. My guess is you kind of have some background in some of these eating disorders, right? So that's very unhealthy. Ketogenic diets emphasize carbohydrate restriction while generally ignoring total calories and the dieter's cholesterol and saturated fat content. This was kind of once billed or coined as the diet revolution and championed really by late Robert Atkins. Dr. Atkins was a doctor, 1930s. He died in 2003. So a version of the diet was first promoted in the late 1800s and has appeared in various forms since then. Long disparaged by medical establishment, advocates maintain that resting daily carbohydrate intake of to 20 grams or less for the initial 2 weeks with some flexibility afterward causes the body to mobilize considerable fat for energy. This generates, however, excess plasma ketone bodies, right? This is the byproduct of incomplete fat breakdown from inadequate carbohydrate catabolism. Ketones supposedly suppress appetite. Theoretically, the ketones are lost in urine, represent unused energy that should further facilitate weight loss. Some advocates claim that urinary energy loss becomes so large that dieters can eat all they want and just restrict calories, but we know that weight maintenance is always the problem. So Atkins type high-fat, low-carb diets require a systematic long-term evaluation up to 5 years for safety and effectiveness, particularly in relation to the blood lipid profile. So the diet places no limit on the amount of fat, meat, eggs, cheese a person consumes possesses really 9 big potential hazards, right? It's 1, raises serum uric acid, potential development of kidney stones, alters the electrolyte concentrations to initiate cardiac arrhythms. 4, causes acidosis. 5, aggravates existing kidney problems from the extra solute burden in the renal filtration system. 6, depletes glycogen reserves, contributing to really fatigued problems. 7, decreases calcium balance and increases the risk for bone loss. Causes dehydration. And 9, slows fetal development during pregnancy and with inadequate carbohydrate intake. Especially thinking about high performance endurance athletes who train at or above 70% of their maximum effort, switching to this high-fat diet is very ill-advised because the body needs to maintain adequate blood glucose and glycogen packed in the active muscle and liver storage deposits. So fatigue during intense physical activity for more than 60 minutes duration is going to occur much rapidly when athletes are engaging in high-fat ketogenic diet. Low carbohydrate, high protein diets may shed pounds in the near term, but their long-term success remains questionable and may even pose health risks. These diets have been promoted to the overly fat as so-called last chance diets. Early versions consisted of protein in liquid form, advertised as so-called miracle liquid. Unknown to the consumer, the liquid protein mixture often contained a blend of ground up animal hooves and horns and pig skins and all of this broth and enzymes and these different tenderizers. to pre-digest it. So really collagen-based blends produced forms of gelatin hydrolysis supplemented with small amounts of essential amino acids did not contain the highest quality amino acid mixture and lacked vitamins and minerals, particularly copper. So a negative copper balance coincides with electrocardiographic abnormalities, very rapid heart rate. Protein-rich foods often contain high levels of saturated fats, which also is going to increase the risk for heart disease and type 2 diabetes. Diets excessively high in animal protein increase urinary excretion of oxalate, and a compound that combines primarily with calcium to form kidney stones. Dieter safety improves if it contains high-quality protein with ample carbohydrate, essential fatty acids, and micronutrients. Some urge that extreme high protein intake suppresses appetite through reliance on fat metabolism and subsequent excess ketone formation. The elevated thermic effect of dietary protein with its relatively low coefficient of digestibility, really that of plant protein, reduces the net calories available from ingesting the protein compared to the well-balanced meal of caloric value. So the point here really has some validity, but one must consider factors when formulating a really sound weight loss program, particularly for people that are very physically active. So therapeutic fasting, or we call this the very low calorie diet, may benefit severe clinical obese patients where body fat exceeds 40 to 50% of body mass. So the diet provides between 400 to 1,000 calories daily as high quality protein foods or liquid meal replacements. Diet prescriptions usually last up to 3 months, but this is only used as a last resort before undertaking more extreme medical approaches for morbid obesity that include usually surgical treatments, bariatric surgery. Surgical treatments that considerably reduce stomach size and reconfigure the small intestine induce a sustained weight loss, but are only prescribed for patients with a BMI, as you guys all know, greater than 40 or BMI of 35 when accompanied by other comorbidities. Dieting with the VLCD diet, right, this very low calorie diet, requires very close medical supervision, usually a hospital setting. Proponents maintain that severe food restriction breaks established diet habits, which in turn improves long-term prospects for success. These diets may suppress or depress appetite to help compliance. Daily medications that accompany the VLCD, the very low-calorie diet, include calcium carbonate for nausea, bicarbonate of sodium, potassium chloride to maintain consistency of body fluids, mouthwash and sugar-free chewing gum for bad breath, and high levels of ketones from fatty acid catabolism, bath oils for dry skin. For most individuals, semi-starvation does not compose the ultimate diet or proper approach for weight control. The other thing to look at is hydration level and duration of the energy deficiency affected during the amount of composition during weight loss. Approximately 70% of our weight loss over the first week of energy deficit consists of water. Thereafter, water loss progressively lessens, representing only about 20% of the weight loss in second and third weeks. Concurrently, body fat accelerates from 25 to 70%. During the fourth week of dieting, reductions in body fat, about 85% of the weight loss without further increase in water loss. So protein's contribution to weight loss increases around 5% initially, and then it goes up to about 15% after the fourth week. In practical terms, really counseling efforts should emphasize the weight loss during the initial attempts to reduce weight, and then when this is successful, consists really mainly of water, not fat. It takes about 4 weeks to establish the desired pattern of fat loss for each pound of weight loss that somebody's going to lose. So this figure represents the general trend for the percentage of composition of daily weight loss during those first 4 weeks of dieting. Restricting water intake for the first several days of a calorie deficient diet increases the proportion of body water loss, and decreases the proportion of fat loss. More total weight loss occurs with restricted daily water intake, but additional weight loss comes solely from water as dehydration progresses. Dieters lose the same quantity of body fat regardless of the fluid intake level. After about 8 weeks on a diet, the caloric equivalent of weight loss exceeds twice that in the first week and continues to increase throughout the 25-week period. The points of importance of maintaining a caloric deficit for extended duration is very, very important. Short periods of caloric restriction produce larger percent of water and carbohydrate loss during loss per unit of weight reduction, with only minimal decreases in actual body fat. So this figure is reinforcing that important concept that caloric equivalent of weight loss increases as the duration, the time of caloric restriction actually progresses. So conventional wisdom views excessive food intake as the prime reason why our nation is in what we call an overfat state. Many believe the only way of reducing unwanted body fat requires caloric restriction by dieting. Very overly simplistic strategy partly accounts for the dismal success in maintaining weight loss over the long term. So refocusing the debate on the contribution of food intake with obesity, looking at sedentary lifestyle consistently emerges as an important factor in weight gain with children, with adolescents, and with adults as well. So excess weight gain often parallels reduced physical activity rather than increased caloric intake. Physically active individuals who eat the most often weigh the least and maintain the highest levels of physiological fitness. So excessive fatness relates directly to the number of hours we spend watching television, a consistent marker of inactivity among children, adolescents, and adults. For example, 3 hours of television viewing a day led to a 2-fold increase in obesity and a 50% increase in diabetes. Each 2-hour per day increment of TV watching coincides with a 23% increase in obesity and a 14% rise in obesity and diabetes risk. So excessive television watching, playing video games, remaining sedentary is really important. So 2 arguments attempt to counter the increase in physical activity approach to weight loss. One maintains that physical activity inevitably is going to increase your appetite to produce a proportionate increase in food intake that negates the caloric deficit increase with physical activity. The second argument claims that relatively small calorie burning effect of normal exercise workout does not dent the body's fat reserves as ineffective for food restriction. So in essence, a weak coupling exists between short-term energy deficit induced by physical